morning, everybody. So this is a brief overview of all of the valves. It's a little bit of a misnomer because it's really just 3 valves plus maybe a little bit of one. So I'm just going to get started. All right, so I just want to start off by thanking Dr. Moreira, Dr. Hannison, and Dr. Kilpatrick, who helped with some feedback on this. And I didn't add it in here, but I wanted to thank Dr. Teddy Segura for informing me just how much I don't know about valvular pathology, which sort of inspired this. Okay, so the goals of this lecture are not to go over everything. I just want to highlight my goals. So I want to introduce some valvular pathologies, a small amount of advanced echo concept. I want to focus primarily on the qualitative assessment of valvular pathologies, and I want to provide a little bit of clinical information to help frame the management of valve pathologies. And mostly, I just want to generate some interest in advanced echo and maybe inspire some self-study or future electives. I know a number of people have done the Dr. Vidarakis elective and have really, really enjoyed it, as well as advanced ultrasound within our own department. So what are not the goals? I'm not going to cover the full spectrum of valvular pathology, pathophysiology, and management, so don't expect that. I'm not going to teach you how to do comprehensive grading of severity for every lesion, and I'm not going to help you pass your echo boards. And I don't want everybody to come out of this lecture deciding that they're now going to ignore all the things that we've learned up until this point, like EF, D-sign, and effusions, and start commenting on every little valvular pathology. Remember, your bedside echoes are limited. Focus on the things you know. This is just to add a little bit of additional information so that, as Dr. Kilpatrick just mentioned, you know when things are abnormal. This can now help you to determine what might be abnormal, but I don't want everybody to focus on these concepts instead of what we already know. Okay. So briefly, I'm going to touch on just a couple of these topics. It's a big list, so I'm going to go over the background, anatomy, including some Doppler Jet Anatomy, a very little bit on physics. The meat of this lecture is on the mitral and aortic valves, and then I very briefly touch on the right-sided valves, but they really never get any love anyway. So here's your basic anatomy. Okay. You can see the valves in the coronal view as well as at the level of the annular plane. I think a lot of us are pretty familiar with this, but it's just helpful to reorient everybody. The valves in systole, we can see the aortic and pulmonary valves open and the atrioventricular valves are closed. And then in diastole, we can see the AV nodes are open. One thing I wanted to point out is just how much bigger the AV nodes are, and that correlates with the much lower pressures that they're handling. Okay. And then for anybody who's forgotten the basic anatomy, the tricuspid valve has 3 valves, mitral valve has 2. So if you're seeing signs of that on echo, just it can help to reorient you. For our ultrasound views, this is your typical apical 4-chamber, which I think we all know. It's really helpful for identifying the mitral valve and tricuspid valve. And most of the advanced stuff takes place in this view, especially the Dopplers, quantitative Doppler, and a lot of the good information that we get from color Doppler. The apical 5 is basically just a small variation on that last one, and it's really helpful for identifying primarily aortic regurgitant jets and allowing for quantitation of that because it gives us the LVOT.
For your images.
Yeah, it gives us the LVOT and a little bit of the aortic valve as well. And then the other one that we're very commonly going to visualize is the Parasternal Long view, which completely misses the right side, but gives us a good view of the mitral valve, the LVOT, and hopefully the aortic valve if you can get that image just right. All right. So when do you want to echo for valvular pathology? When do you want to consider it? Obviously, in a patient with known valvular disease, but with changing symptoms, that's going to be your single biggest indication every single time, and it's the one that you don't want to miss because these can sometimes become surgical. And then obviously our physical exams are important. We could all probably improve a little bit, except for Dr. Silverberg, who I know is spot on. But the systolic murmurs, you want to focus on these when you have a 2+ murmur that is associated with some cardiovascular disease. If you see edema, Rales, JVD, or if you see an abnormal EKG or chest X-ray that has not been identified before, or has changed from prior. And then loud murmurs, 3+, mid-systolic murmurs, hollow-systolic murmurs. Honestly, I've never heard these. I just lied every time I said I heard these. Yeah, I'm not good at this. I think we could all, especially me, work on this a little bit. But any diastolic murmur, these are actually somewhat easier to identify, especially if you're feeling for pulse when you're listening. All diastolic murmurs are pathologic. So if you identify one, if you think you identify one, look for them. And just some of the presentations to consider. Most of the time, we're going to see stenoses and chronic regurges. They're much more common, and they tend to present with dyspnea on exertion, progressing to shortness of breath at rest. They can present with palpitations, which are primarily atrial in origin, like PACs, new onset AFib, atrial ectopy, things like that. And then for the purposes, I was signed on to another. Okay. For the purposes of testing, try to remember the aortic stenosis triad of dyspnea, chest pain, and syncope. You probably won't see it always in the real world, but it is one of those triads that gets taught. And for the acute regurgitations, those are much more severe and acute in their presentation. They often present with severe shortness of breath, acute onset pulmonary edema, and they can progress to new onset CHF, cardiogenic shock, or cardiac arrest. So if you have patients who were completely fine and now have these dramatic symptoms, a lot of the time it's going to be your bread and butter APEs, but it's something to keep in the back of your mind, these new onset regurges. All right. And now I want to move briefly into the Doppler jets. I spent about an hour looking at that jet, and it is similar to Doppler jets. They are very cool if you spend some time learning them. So Doppler jets have their own anatomy, which I found very interesting. We all kind of know the jet itself, which is defined by the jet length and the width. Together, that makes the area. And the total jet area correlates with the volume of the flow behind it, either the regurg volume or the stenotic volume. The things that I found interesting were that at the level of the valve leaflet, there's a narrowing, which is the highest velocity section, and that's called the vena contracta. If you're doing quantitative assessments of these jets, you can actually measure the vena contracta, and the size of the vena contracta tends to correlate with severity. That's not our goal. Our goal is just to know that this exists. And then similarly, there's an area immediately preceding the valve. This jet is a regurg jet, and the flow convergence is an area that you're going to identify on color Doppler. That is the blood essentially speeding up to match the speed of that high velocity vena contracta, and you can usually see it right before it passes through the regurgitant area before proceeding on and becoming a big jet. And the flow convergence is also correlated with severity. There are numbers behind this. I don't think we care about those numbers. It's just if you see these and if you see them and they're big, it definitely indicates a degree of severity. So it's just something to consider and something new that I learned and I thought was. So these are actual examples of the Doppler jets, both in mitral regurg and mitral stenosis, sorry. You can see the flow convergence area, the vena contracta, and the jet expansion areas. And what I liked about this is that it's two different pathologies, but the underlying jet anatomy holds true. So I just thought it was really interesting. You're not going to see it in a lot of them. You know, your typical jet is going to be mild. You're not going to see the vena contracta. You're not going to see the flow convergence. But when you identify these, just it increases your suspicion for moderate to severe disease. And this is just a highlight of these flow convergence zones. There's a method of analyzing this called the PISA method, but it was so long and so boring, I'm just not able to touch it. Okay, and then briefly, I'm just going to touch on some of the physics that guides a little bit of this. Nobody's getting tested at the end of this. It's just you're going to learn just a few new words. The first one I want to touch on is this concept of aliasing. Aliasing is that rainbow color storm that you see on the left. Basically, it represents abnormal coloration because the machine is freaking out and it's detecting velocities above what's called the Nyquist limit. The Nyquist limit is basically an intrinsic property guided by ultrasound physics, and it has to do with the intrinsic rate of the pulse frequency that's being released. You don't care about that. All you care about is rainbow color is velocity above a certain threshold. That's all you need to know. It doesn't really give you a lot of information about direction, but usually with these jets, you can identify the direction just based off of, is it going into the atria or is it going into the ventricle? So you don't really care about these colors so much with big jets. You just want to know that this is high velocity, okay? And then briefly, how do we measure some of these velocities if we wanted to do some quantitation? We can use either PW or CW. So what's the difference? Basically, PW is the one that we often use. It's the one where we drop the little gate exactly where we want to measure, and we measure a certain velocity. What it does is it releases a pulse. That pulse is then stopped, and the machine waits for that echo to come back. And you can target a certain distance by deciding how long you want to wait. If you send a pulse and you wait longer, that's a farther distance, right? So that's where you can get really good range resolution. But the problem is that you're subjected to this Nyquist limit. And so it muddies velocities above a certain limit. So you get over this by using what's called continuous wave Doppler. Continuous wave uses one part of the probe to send a signal and another part to listen to a signal. So always sending and always listening. So it can't identify a really small range. It can't drop a gate exactly where you want, directly above or directly below a valve. All you're going to get is an axis along that sensitive region, okay? And it's going to pick up the fastest velocity in that region. So it's really good for velocities above the Nyquist limit, but it completely fails to identify exactly where along that axis it is. And this is relevant if you want to do some measurements. Basically, if you drop the PW wave right at the level of the mitral valve, we can see the typical EA waves. But if there is a mitral regurg that is sort of being detected, you get this complete disaster on the other side when you try to pick it up in PW because the flow is above the Nyquist limit. And you would see it as aliasing on color flow, but for the purposes of the quantitative Dopplers, it just looks like a total mess. When you do it in CW, it looks like that. So it's much more defined. You don't know exactly where it is, but you know how fast it's going. So that's some of the underlying physics. So just in review, aliasing was abnormal color signal above the Nyquist limit, representing high velocities. Pulse wave Doppler is great for measuring velocities of flow at a particular location, but for velocities above this Nyquist limit, it's a disaster. And continuous wave Doppler is great for measuring those high velocities, but it can't use range resolution. All right. So now onto some of the valves. So I'm going to start off with mitral stenosis. Unfortunately, this one was a good gift, but yeah, it did that on mine too. So what's important to identify on mitral stenosis is the decreased motion of the mitral valve, but specifically the narrowed valve opening. You can often see calcification of the valve, which is not present on this one, and you can see what's called hockey sticking. Hockey sticking is where it's primarily in rheumatic disease, and it's where you see this very narrow stenotic opening of the valve itself, but during diastole, you see a ballooning of the rest of the valve, and you get this kind of like hockey stick appearance. And that becomes relevant when you're trying to compare a stenotic valve to, for instance, a lobia. So on the left, we can see a stenotic mitral valve, and it's giving us all of those features. Well, it's not really calcified, but it's narrowed, and you see this diastolic ballooning with the hockey sticking, which you don't see in the low EF version. The other thing I want to point to is that the mitral stenosis echo doesn't have the other features of low EF heart failure. You don't see the same degree of hypokinesis. This is slowed, unfortunately, but it's really not a hypokinetic LV. And you don't see the same degree of LV hypertrophy that you see in the low EF version. So I don't want people to start saying that they're seeing a whole bunch of mitral stenosis when it's really just low EF. This is the main ways that you can try to identify the difference. And this is what mitral stenosis looks like with the jets. Obviously, the jet is moving into the LV from the LA. And when you have more severe disease, you get more aliasing. You get a bigger flow convergence zone. And you can see this in multiple different views. This one on the left is your apical 4. The one on the right is not exactly anything. But you could pick this up in multiple different views. So I'm going to move briefly on to mitral regurg. I think we all know the basic pathology behind it. That regurgitant flow goes from the LV into the LA. And this is what it's going to look like on your typical apical 4 chamber. But how do we decide how severe any of this is? There's a million ways to semi-qualitative or semi-quantitatively define it and quantitatively define it, and basically nobody agrees. It's incredibly hard to do. So we're just going to focus on qualitative signs, and the ones that I want you guys to focus on are mild and severe, and anything that's not mild and anything that's not severe is moderate. We've learned the 1/3, 1/3, 1/3, which is a very good approximation, actually. A lot of things I looked at cited that. But just for a little bit deeper information, a mild jet is sort of defined as having a jet area less than 20% of the atrial area, or less than 4 centimeters squared. But nobody's going to like actually measure it. So just look for less than 20% of the atrial area. Okay. For severe jets, you want to identify a jet with greater than 40% of the atrial area, or if you identify these other things. One would be the Coanda effect. Another one would be a very large convergence zone, which simply won't show up in mild or moderate disease. And then if you see a rupture of the chordae or the papillary muscles, that automatically defines severe disease. And like I said before, if it's not severe and not mild, just call it moderate. So this is what mild looks like. It's very clearly less than 20% of the left atrial area. One of those weird effects is called the Coanda effect, and it's when you have a jet area or a jet that basically hits the wall and it doesn't dissipate. It indicates a large volume moving, a large regurgitant volume that is not, the energy is not dissipated when it hits the wall. So it may not be exactly 40%. It might look like it could be moderate, but if you have pretty much any degree of Coanda effect, it's agreed that it's a severe regurg. And so here you can see sort of two examples. They're both severe. One is greater than 40%, but it's central. The other one, I'm not sure, it's probably close to 40%, but because it has this Coanda effect that sort of bounces off the wall, it's defined as severe. So these are a couple things that you can look for and just were kind of interesting. And again, for some comparisons, you can see super impressive severe central jets. You can see multiple eccentric jets if valves aren't meeting up in different ways. Basically, the jet can do whatever it wants. So you're not always looking for just the classic right down the middle type of jet. And then this is an example of the papillary muscle rupture. I don't have it in color flow because I don't think you need it. It's pretty dramatic when you see that thing flopping around. Obviously, you want to make sure that from a clinical standpoint, you're not concerned about endocarditis, because this thing could have been a vegetation, but in right clinical context, for instance, a week or two after a big MI, and now coming in with severe pulmonary edema, this is not the typical presentation of endocarditis. So if you see this, call a surgeon. You know, this is real deal. And then I briefly want to touch on mitral valve prolapse. I don't really have much to say about it other than it's pretty subtle. I'd rather focus on the one on the left because you're not seeing a full flail leaflet, but obviously symptoms are correlated with the degree of regurgitation. If you see this and they don't have known disease, it definitely warrants a formal echo, but it's not really as devastating as some of the prominent MRs. It's just something to note if you see it. So some of the surgical indications for mitral disease, if you have severe MR or MS with symptoms, that becomes a surgical indication. If you have severe disease on echo and you don't have symptoms, then a lot of the times the surgeons will want to wait. Another indication would be if you have any other indication for cardiac surgery. For instance, if you have a dilated aorta, if you need a CABG, if you have anything else going on and you have severe or even relatively moderate disease, a lot of times the surgeons will replace the valves at that time. And then if you have new onset CHF, which obviously is symptomatic, or a dilated cardiomyopathy, or what I thought was kind of interesting is new atrial fibrillation or new pulmonary hypertension is actually a surgical indication. So if you have a patient with new onset AFib, and you happen to go back and identify them as having a valvular lesion, that actually is a surgical indication. You can help move them along by either admitting them, consulting them, or just having them follow up with CT surgery. And then very lastly, I just want to talk about mitral valve endocarditis. Obviously, you're going to focus on this when you have the right clinical context, fevers, various embolic phenomenon, and just look for vegetations primarily. Although if you're really good, you can identify what are called periannular abscesses or perivalvular extension. And this can actually become really bad because it's much harder to treat. A lot of times these require some surgery, but I'll touch on that later. Moving on to the aortic valve. The things I want to highlight about this is just how immobile that aortic valve is. Obviously, you need to get a good view of it, but usually the aortic valve is not nearly as limited. And the most common cause of aortic valve disease would be sort of dystrophic calcifications related to age. And the second most common would be in the context of rheumatic disease, but both of them can see this significant narrowing of the valve opening. And you're often going to see in chronic disease a very hypertrophied LV that's been pumping against this wall for a long time, and they can have normal to low EF. For this one, there's not a lot more to talk about, so I wanted to just briefly bring up a clinical consideration on this. If you had a patient who came in with respiratory distress, chest pain, and flash pulmonary edema, and they presented with a similar echo but a slightly lower EF than this, what would you consider? Would we go to our normal ABCs BiPAP nitro? Might not be a great idea if you see this on your echo. Dropping preload and afterload can dramatically worsen the cardiac output with aortic stenosis specific. So proper identification of this lesion might dramatically change your management. Better idea on this patient is actually to support the preload, support the afterload, give them a little bit of inotropy to increase their cardiac output, and actually transfer these patients. Balloon valvuloplasty would be life-saving. And Kim Christoph and I had a patient like this who went into VT storm for almost a day and a half before he went to myo, got balloon valvuloplasty, and is completely fine. So this is relevant but rare. Moving on, I'm going to talk about briefly aortic regurg. This is what it looks like on your parasternal long. Note the degree of aliasing. These are high velocity lesions. So they have a lot of pretty colors, which you can look at for a while. And then in the apical 5-chamber view, you want to identify the LVOT and try to get the aortic valve to get really the right jet, because if you're off by a little bit, your mitral valve is going to be right to right on your guys' side. So you want to make sure that you're identifying it as coming out of the LVOT before you make a diagnosis. I think I made that mistake. And so now, how can you quantify these lesions? This is the only time I'm going to give you a little bit of math because I find this particularly interesting, but I'll go over it pretty quickly. The best way to do it that I've identified is by going into your apical 5-chamber and dropping a continuous wave dot right along that LVOT, right along that jet. And then when you measure it, you get what's called a pressure half time. So how does that work? Basically, a more severe regurg allows more blood through the valve in any amount of time. And the regurgitant volumes correlate with the severity. Larger volumes allow the aortic pressure to equilibrate with the LV pressure faster. When you have a greater pressure drop, you see a greater drop in velocities, and that drop in velocities that happens faster as that pressure equilibrates. So when you're measuring this, you can see it as less severe disease on the left. The velocities stay high as compared to the right, but it's not really to scale here, but actually that drop from the high corner to the low corner actually is much longer in mild disease as compared to severe disease. And so if you measure the time axis along that view, it actually correlates with the degree or with the severity of disease. And it's much easier to do than people think. On the machines, they have a dedicated setting. You just measure the time axis, or you just put 2 points on those 2 corners, and it will identify the time axis for you. It's pretty cool. And mild disease is obviously a longer pressure half time, whereas severe disease is a shorter pressure half time. And so I've done a bunch of these, probably too many because I was just interested. but it can be helpful. You know, it can definitely be helpful, and it might expand some of your horizon. So I just want to bring it up. And then lastly, for the aortic valve, or actually second to last on the aortic valve, I wanted to briefly touch on prosthetic valves. They look totally different. The bioprosthetic valves can look pretty similar. Sometimes you're going to see some abnormal shadowing because of suture scars or other areas. So they weren't as interesting, but at least for the mechanical valves, they're going to have a lot of artifact going on. And with these, honestly, don't waste your time trying to identify regurgitations or anything like that. The big money on this would be to identify vegetation. Any vegetation with a prosthetic valve is a big time problem and needs essentially emergent surgical consultation. But they're just kind of cool looking, so I want to bring them up. And then this is kind of what your vegetation is going to look like on the mitral valve, I'm sorry, on the aortic valve, but we also have mitral valve vegetation. So remember, with endocarditis, it's not one valve, it can be lots of valves, it can be all of them. And you may not see vegetations, like I said, you can see these periannular abscesses and whatnot, but when they're prominent, they're pretty prominent, and a lesion like that, it's not going to be just the vegetation. You're going to see some degree of regurgitation. You're going to see hemodynamic changes associated with this. So if you have a patient who's like IVDU and has risk factors and some presenting symptoms, just consider taking a look. So when would you want to get a surgeon for endocarditis? Kind of the same things, new onset CHF, new AFib, things like that. But also, if they're having persistent infectious symptoms despite adequate antibiotics, if they come back and they've got a PICC line or a midline and they've been in the outpatient world getting their antibiotics and they're still having persistence, that's an indication. If they're having a systemic embolic phenomenon despite being on antibiotics, if they have a prosthetic valve, or if they have large vegetations, I don't think I care too much about these numbers. If I see something big, I'm bringing it up. And then obviously, if you identify periannular extension, but basically, if you identify any of these things, load the book, get them admitted, and potentially transfer. Briefly on the right side, I don't have a lot of time, but I don't have a lot of information, so that works. Basically, tricuspid valve regurges, you just want to know that they're pretty common. If you identify this, it's not pathology, not by definition. If it's dramatic, it can be pathological, it can lead to symptoms, but it's exceedingly common. Basically, the only interesting thing about this that I looked into was if you're a nerd like me, you can drop CW gates on the regurgitant jet, and it can correlate with the degree of pulmonary artery systolic pressure, and pulmonary hypertension can be useful in identifying things like onset PE or chronic pulmonary hypertension or a pH crisis. And it's been fairly well established that the tricuspid regurg velocity correlates with right heart cath measurements. But when you do the calculation on the machine, at least according to David Smith, it doesn't correlate particularly. The velocity correlates really well, but the machine's calculation based off of that velocity is not exactly perfect. And that's the number that you get on your echo reports. So take those numbers with a grain of salt, but when they're high. That's kind of the point. And then this was a dramatic tricuspid endocarditis, so I had to include it. Consider these guys specifically on your IV drug users, right? Because everything's coming from the venous side to the right side of the heart. And they can present with lots of pulmonary symptoms, septic pulmonary emboli, and chest x-rays and CTs with lots of abscesses. So if you see that, consider doing your own echo. You might see something really, really crazy. And then lastly, the pulmonic valve. Honestly, it's too hard to find it useful. That's kind of what I identified. Chris will tell you more about 60/60s and other fun things like that. If you have the time and you're interested, definitely try to look for it. You can identify this view at the parasternal short axis by riding up high to the base with the aortic outflow. And then you can see kind of this looping around to identify the pulmonary trunk and the two right and left pulmonary arteries. It's a cool view to try to get. So I suggest you try, but it's beyond the scope of this lecture. So I think in summary, what I wanted to bring up for this is remember your availability bias. If you don't consider valvular pathology, you're never going to diagnose it. So when you do consider it and you have the time to echo people, just take a look at the valves with and without valves. You might see something cool. Many valvular pathologies can be readily identified with qualitative assessments. They don't require quantitative assessment. I mean, they do, not at our level. And they don't require board certification in any of the echo specialties. And identification of valvular pathology can dramatically alter management, patient outcomes, especially when acute or severe. And you might really help somebody out by identifying these things early and loading the boat early, transferring them so they don't push on medicine for. So anyway, thanks. Here are some of my references. A lot of authors I want to point out on the Focus Atlas. I didn't list them all, but I have a list if anybody's interested. Great website. Any questions?
Question, Dr. G.
I just want to make a comment, not on this. This is way beyond me, but not smart to follow it. But you made a comment about difficulty hearing diastolic murmurs, and they can be, but there are some tricks you can do with your stethoscope.
Yeah.
So for mitral stenosis, I'm sorry, for mitral stenosis, you should suspect it, obviously, always diastolic murmurs when you hear a systolic, but they may go together. That's one time you should suspect. With mitral stenosis, you should suspect that if you have rheumatic disease, and also if they're getting recurrent pulmonary infections and things like dyspnea on exertion. And the best way to hear mitral stenosis is to put them in the left lateral decubitus. Use your bell because it's a low frequency sound, mitral stenosis. And you may, if it's from rheumatic disease, you may hear an opening snap during diastole. And then, though, you'll hear the mitral stenosis. It's right before S1, right before systole starts, so right before it, and it's a rumbling sound. You have to listen carefully and quietly, so you'll never hear it at UHB.
Right.
For aortic insufficiency, the best way to hear that, you should suspect that, again, if they have aortic stenosis, and especially if they're getting bad failure that's not responding, because that's how it usually presents with bad failure. And they'll also, bad aortic regurg will have very wide pulse pressures when you do the blood pressure with very low diastolic pressure. And the pulse will be what's called Corrigan's or Water-Hammond's pulse. When you feel the pulse, it goes boom, it hits you, and then comes down right away. So the best way to hear that, sit the patient up, lean them forward, have them breathe out and hold their breath in expiration, listen with the diaphragm, and instead of listening right over the aortic area, which is here, listen more in the pulmonic area, which would be second intercostal space, just to the left of the sternum. And then listen for it, and it's an early diastolic sound that you'll hear. So they're still difficult, although especially mitral stenosis, you need quiet rooms, but you can sometimes pick them up and make a difference, and then get someone smart like you to do the
My only request is that if anybody does identify any of these murmurs, please grab me if I'm working. I want to hear them more. I want to learn more because this art of physical exam is something I'm not very good at. So I appreciate that. I'll still let you.
Yeah, then.
Johnny Roger, yeah. So
a lot of value I see in this is kind of comes back to pattern recognition, which is how a lot like just emergency medicine. The value I think in doing 20,000 echoes during your time as residents here is so you could start realizing when, wait a minute, this one's different. Like something's standing out, something's different than the other 19,000, et cetera, that I've done. And so thinking through, do I have to then alter my management based off of what I'm seeing here? In fact, this doesn't clearly fit into the stock that we encountered so many times. Yeah. So I think there's some value in just seeing like a survey of these images in case something ever flashes up when you're following like these patients. Make that connection that maybe I have to process differently. Looking looking at the future of emergency medicine, like as we look across the street and increasingly heart failure and dyspnea patients become moved more to the, well, I want you to do a patient to ops. Come on, it's not. Why don't you manage the patient? Okay, that just invites more concern for, well, how certain are you as to what's going on? No history of THF, that's a big red flag. And then diuresis and distress. Like those patients, we want to pay extra attention to, doing our echo for anything that's standing out. Because in the past, it was, oh, you have a heart, you're in trouble breathing, go ahead, you admit to the hospital, someone else is going to figure it out. Yeah, that's fast medicine, that's not necessarily accurate or safe medicine. And so I think spending a little more time, especially in those particular patients, it has some value, especially when ultimately your name's going to be the one on the chart, you're no longer passing it off to the patient.
Yeah.
Any other questions, comments?
I mean, the more I got interested in this stuff, the more I started looking for it. And there's a lot of disease out there, and you'll identify them. Most of them are pretty mild. Most of them are not change management. But if you start taking the time to consider the diagnoses and start looking for them, you're actually going to find a lot. So I thought that was pretty cool. Any other questions? Peanut gallery? No?
Thanks, Ben.
Cool. Thank you.